Okay, let's unpack this. We are wading into one of the biggest, longest-running disputes in critical care medicine.
Oh, yeah. For years, this was the ultimate professional grudge match.
Which induction agent is safer for intubating the critically ill? It's ketamine versus etomidate for rapid sequence intubation, or RSI.
It really became this almost ideological division in practice. You were either a K-head or an Eto lover.
And the choice was usually based on what you were taught or what you were most afraid of?
Exactly. What kind of terrible outcome you feared most?
Well, that's the tension we need to resolve today, and thankfully we have some really definitive evidence to do it.
We do.
Our source material for this deep dive revolves entirely around a massive, recently published investigation. It's known simply as the RSI Trial.
Right. This was a sprawling, pragmatic, randomized controlled trial in RCT.
Led by Casey and Driver, it enrolled, 2,365 critically ill adults across 14 U.S. hospitals. So we're talking EDs and ICUs.
And our mission here is to move past all the historical anecdotes, the powerful cultural consensus that really dominated the last decade.
We need to see what this massive data set actually revealed.
Because for anyone trying to stay current in acute care, these findings, well, they fundamentally change the prevailing wisdom about which drug is safer.
Yeah, and more effective, because the stakes here couldn't be higher.
Mm.
When you're intubating a crashing patient, especially one in profound shock, that choice of induction agent is. It's one of those small clinical moments that could cascade.
Theoretically, yeah, into a devastating outcome.
So let's start by setting the historical stage. I mean, why did this conflict even exist in the first place?
Well, Etomidate was king for decades. Its primary selling point was just undeniable, outstanding hemodynamic stability.
It didn't cause that massive blood pressure crash.
Exactly. Not like what you'd see with drugs like propofol. It was the steady hand for the absolute sickest patients.
It was reliable, but then came the shadow over its reputation, the ghost story.
That ghost story centered on this really elegant, powerful biochemistry. Etomidate inhibits a crucial enzyme in the adrenal gland 11-beta hydroxylase.
Okay, and the effect of that is?
It just stops the production of cortisol for up to 72 hours. This is what we call adrenal suppression.
And that mechanism felt so satisfyingly correct, didn't it?
It did. The theory basically became dogma. Cortisol is essential for managing stress, for maintaining blood pressure, especially in sepsis.
So if etomidate blocks cortisol,
Then it must worsen shock, and ultimately it must kill septic patients. It was a beautiful, powerful argument.
I remember feeling that anxiety in training. The sources note this fear got so powerful that a lot of clinicians just abandoned etomidate completely.
Some countries even pulled the drug from their market, entirely based on that biochemical anxiety, not on any definitive outcome data.
And that whole environment just cleared the path for the challenger.
For ketamine, yeah. It rose to prominence precisely because it was seen as the antidote to the etomidate problem.
Right, and here's where we see a classic example of clinical culture being driven by a compelling physiological narrative.
Ketamine is known as a sympathetic nervous system stimulator. It triggers the release of catecholamines, your body's own adrenaline.
Which raises heart rate and blood pressure.
So the clinical reasoning was bulletproof, or so it seemed. If etomidate causes death by depression, ketamine must provide safety by stimulation.
And ketamine became the preferred agent. It was labeled the hemodynamically safe choice, especially for patients who were already hypotensive.
But that preference was largely driven by a compelling vibe, a consensus based on theoretical benefit, often before any large-scale evidence proved it was actually better for long-term survival.
Which brings us to the RSI trial.
Exactly. It was designed to ignore the biochemistry, ignore the vibes, and just ask the practical question. Does the choice of drug actually matter for survival?
Let's talk about the patients they studied, because they really went after the sickest of the sick.
Well, they did.
These were critically ill adults. Trauma was excluded, median age around 60. And to give you some context on just how sick these folks were, nearly half, 46%, had sepsis or septic shock.
And 22% were already on vasopressors before they even got the induction drug.
Wow.
And if you look at their baseline illness severity, which the sources track using the Apache 2 score, the median was 18.
So for you as the learner, you should understand that an Apache 2 score of 18 means this patient group was substantially sicker than your average ICU admission.
Way higher risk. They really stacked the deck against both drugs to see where they would fail.
So the trial measured the one thing that ultimately matters, in-hospital death by 28 days.
That's the primary outcome.
They compared ketamine at a median dose of 1.6 milligrams per kilogram against etomidate at 0.28 milligrams per kilogram.
And result, well, it landed like a huge, surprising thud.
What did he find?
Mortality was essentially identical. Ketamine was 28.1% mortality versus etomidate at 29.1%.
Less than a 1 percentage point difference.
And the stats showed it was pure chance, p-value of 0.65.
So, a statistical non-event. The grudge match for survival ended in an unambiguous draw.
That no result is the primary finding. And critically, this held true when they looked at the subgroups.
So it didn't matter if the patient had sepsis or shock.
Nope, didn't matter. The pathophysiologic rationale we feared for decades, that etomidate's adrenal suppression would kill patients. It doesn't hold up clinically in this massive trial.
The anxiety was a red herring.
It was an intellectually satisfying red herring, but yeah, a red herring nonetheless.
That is a profound moment for critical care. I mean, the elegant biochemistry was just totally overshadowed by the noise of actual human critical illness.
It is. But we have to mention this statistical caveat, just as the authors did. This trial was designed to detect a pretty large mortality difference.
Over 5.2%, right.
And what that means in practical terms, for you as a listener, is that while they observed about a 1% higher mortality in the etomidate group,
The trial just wasn't big enough to say if that small difference is real.
exactly, it lacked the power. Now, if a huge study one day proved that ketamine saved 1% more lives, that would be clinically massive. But based on the data we have right now, the choice has no proven impact on survival. The field is liberated from that fear.
Okay, so etomidate is off the execution block. But now we move to the secondary outcome, and this is where the trial delivered the genuine shock.
Yeah, this is the trial's most uncomfortable revelation. It completely upended clinical consensus.
We're talking about hemodynamic stability.
Right. They measured cardiovascular collapse during intubation. That was defined as systolic blood pressure dropping below 65, needing new or more pressors, or cardiac arrest within 2 minutes.
And the drug that everyone, including me, believed was the great protector.
The hemodynamically safer choice.
It was actually the destabilizer.
That is the painful flip. Cardiovascular collapse happens significantly more with ketamine, at 22.1% compared to etomidate at 17.0%.
A 5.1 percentage point difference. That strongly favors etomidate for stability.
And that difference was magnified in the sickest subset.
So in the sepsis patients,
Exactly. In patients with sepsis or septic shock, the very group ketamine was supposed to save, the collapse rate with ketamine was a staggering 30.6%.
with etomidate.
It was 20.9%.
Right.
It's almost a 10-point difference in procedural collapse.
So not only did ketamine fail to save more lives, it actively led to more blood pressure crises during the procedure. This totally contradicts the narrative. Why?
What's fascinating here is, well, we have to confront the gap between theory and reality. The trial shows that the physiological mechanism we all learned
Ketamine as a sympathetic stimulator.
may not hold true in the context of profound, real-world critical illness.
Why does that stimulation fail in the sickest patients?
Because when a patient is that ill, especially in septic shock, their body is already maximally stimulated. They've dumped all the catecholamines they possibly can.
So their reserves are exhausted.
They're gone. So when you give ketamine, you're left with its other effects.
Yeah.
Its direct myocardial depressant and peripheral vasodilator effects.
So in a patient with deep shock, the sympathetic kick gets completely overpowered by the drug's inherent ability to depress the heart and relax blood vessels. The physiology flips.
It flips from helpful to harmful. It just becomes another powerful sedative that, in a patient on the edge, pushes them over. But we have to deconstruct this outcome carefully,
Okay.
because there are crucial methodological critiques noted in the sources.
Right. So if ketamine causes more collapse but not more death, how bad were these collapse events really? This was a composite outcome, right?
Absolutely. Critics call this secondary outcome a methodological mess. It's a composite that lumps together potentially trivial events
Like a doctor just bumping up a norepinephrine drip for a minute.
with catastrophic events like cardiac arrest.
That's a huge distinction. A momentary tweak to a pressor is just part of intubating a sick patient. Cardiac arrest is a failure.
Precisely. So we can say ketamine caused more hemodynamic events, but we can't say those events were necessarily catastrophic given the mortality data.
And what about bias? This was an unblinded open-label trial. The doctors knew which drug they were giving.
That's a huge piece of the puzzle. It's theorized that doctors, having been trained for decades to fear etomidate, might have been hyper-vigilant.
So they might have been more aggressive with pressors in the etomidate group.
Exactly. More proactive. artificially stabilizing those patients because they were expecting a problem, whereas with ketamine, they were expecting it to do the work for them.
That is a massive bias driven entirely by clinical culture.
It is. And then we have the analgesia theory, which I think provides the most nuanced interpretation of all.
Let's dive into that. Ketamine gives you analgesia and sedation. Etomidate is only a sedative.
Right. So when you intubate a patient with etomidate and a paralytic, they are experiencing the procedure, the laryngoscopy, the tube, without any pain relief. That pain is a massive sympathetic drive.
So the pain itself might actually be propping up the patient's blood pressure. The body is using pain as a pressor.
Exactly. When you give ketamine, you provide profound pain relief. So the blood pressure drop we see might not be the drug causing instability.
It's unmasking the patient's true, profound hemodynamic instability by taking away that pain pressor.
It's revealing the patient's
The grudge match is over. Survival is a draw. So what does this all mean for the clinician preparing for their next intubation? How does this change Bortus?
Well, the biggest change is the liberation of etomidate. Clinicians can stop reflexively fearing its adrenal suppression. It's a superb induction agent that is proven safe in septic shock.
And both drugs still have their own specific niche advantages that should guide the choice, rather than these abstract fears. So let's run down that final scorecard.
Etomidate's main advantage is confirmed here: greater hemodynamic stability during the procedure. That's particularly important for the most critically unstable patient whose reserves are just gone.
And ketamine's unique benefits remain. Its powerful analgesia, its bronchodilation for asthmatic patients, its anti-seizure properties.
And it has a longer duration of action, which is a nice safety buffer. It reduces the risk of awareness if your post-intubation sedation gets delayed.
So the most direct clinical implication is you have to stop thinking of ketamine as the magically protective drug for the hypotensive patient.
The data shows the opposite. For patients in severe shock, etomidate may actually be the safer option because it causes less immediate procedural collapse.
The ultimate lesson, and I've seen this in commentary all around the trial, is that the induction drug was only ever a bit player in this huge drama of critical illness.
Exactly. The real success lives in the core processes, not the milligrams you inject. This trial reinforces a non-negotiable principle. You must resuscitate before you intubate.
And you have to be ready to aggressively support hemodynamics no matter which drug you choose.
Focusing all our energy on which drug was better simply distracted us from the quality of the resuscitation itself.
This trial really is a profound case study in medical culture. It reveals how easily a trend, like the belief in ketamine's superior profile, can become a doctrine.
A medical fad.
Yeah, one that completely outruns the actual evidence.
The obsession with a single, elegant mechanism like adrenal suppression proved to be, well, non-consequential to the actual clinical outcome. It was a beautiful physiological argument that failed the ultimate test.
So we need to consider this. If the next medical idea arrives in your department and it feels intellectually correct, it fits a really satisfying narrative, will you ask the critical question that the authors of the RSI trial asked?
Does it matter for patient survival?
That constant demand for high-quality evidence, even when it overturns decades of practice, is the essential humility required in critical care. And that's the thought we'll leave you with today as we wrap up this deep dive.